So first of all, I want to check, do you see clearly? Guys, do you see?
Yes.
Yes.
Yeah, okay. Now let's start our lecture. Today we will talk about the very interesting subject like visual and tactile examination of the caries, and this is very important to make up the diagnosis. And you know that examination by the visual or tactile means is not only one to assess the caries, but it is for today it is the most important. First of all, I will tell you that we have some terms that you should know. And these are primary caries, caries adjacent to restoration, and residual caries. For primary caries stands caries which is on the unrestored surfaces of the tooth. And for the caries adjacent to restoration, this means that we have caries near or under the restoration that we already have on the tooth. The older terminology of this CAR is secondary caries or recurrent caries, and these are more widely used, and maybe for today you couldn't see this term actually the caries adjacent to the restoration used. But you will hear these secondary caries, recurrent caries, because it's more widespread. And we have residual caries. For the residual caries, we have the demineralized tissue, and often this is from the dentin, which was left behind for some reason before the restoration has been placed. And in this case, sometimes we will discuss this, that dentin is not very easy to estimate which one you should leave or which one you should take. So the most obviously this situation is because the clinicians could not recognize dentin wisely, and then we will have residual caries. So primary caries, caries adjacent to the restoration, and residual caries. This is three terms that we will use to describe the caries. So for examination, we need few simple things like good lighting, which is in every dental chair, and also we need a probe which will have very thin head, and we need dry and clean teeth, because sometimes we could not see any caries decay under the thick biofilm. So we will need to clean them if they are not cleaned before, and we will need to dry them to see if there is any defect of the dental hard tissue. For each teeth, we will start examination like from the maxillary side of the right maxillary side, then we'll go to the left maxillary side, then we will go to the lower left side, and the last one will be right mandibular side. So like a clockwise direction. This is always good when you are doing charting, when your assistant is just describing all the teeth and which teeth is affected with caries, and you could dictate to your assistants that you have certain type of caries on the teeth you are examining, and you are examining all the surfaces of the tooth, starting from the distal, occlusal, it may be oral, buccal, or maybe mesiodistal surfaces. And for these surfaces, you always need clear, dried condition. So you use air dryer for the dry surface of the tooth. And as I mentioned, the thin probe, which is perfect to explore texture of the teeth, and dental mirror also is needed for this case. So visually, color changes compared with the appearance of structurally sound teeth are noticed. And tactily, you could feel the irregularities on the morphology of the tooth. So color changes compared with the appearance of structurally sound teeth, you could see, and irregularities you could sense with your hands. So that's why we will tell that we have visual tactile comparison in this case. Yes, so we use color and we will use texture. For the situation when we have biofilm, cariogenic biofilm, we will have, consequently, we will have some evident symptoms like tenderness or pain, but for the first changes to recognize, you could usually see it by the color. And color will change from the yellowish white to chalky white. And if the carious challenge continues, this white area becomes more obvious with time. In next stages, some breakdowns happen, and the mineral and or dark shadow due to underlying carious dentin is observed. This stage is followed by different size of breakdown of the enamel or maybe part of the dentin, and eventually we will have completely destroyed tooth due to the demineralization. Like here you could see in the patient's mouth. Here you could see that we have very small enamel structure and very decayed dentinal structure, obviously destroyed all teeth. We mentioned this kind of situation about the brown spots and scars in the last lecture, if you remember. And here you could see if the progression stops at the early stage, the white tissue appearance starts to get more discolored, and we will have this kind of brownish, like a scar tissue on the tooth. And obviously, we would think to do it or not, because as I mentioned in the last lecture, this kind of scars, they don't tend to progress, and if they are stagnated in this place and if they are not progressing, we don't need to do them. Okay, so the color change, as we said, from yellowish white to chalky white is explained by the dissolution of the minerals, and consequently the intercrystalline spaces get more bigger and pore volume increased. That's why the light is scattered, and visually we get this opaque area that is different from surrounding translucent sound enamel. And you could observe this chalky white enamel here. So obviously this enamel and this enamel is different. So for you to visually detect this, when you see this kind of whitish, and if you dry it out, you could see it gets more chalky white than it is when it is under the saliva. So you could totally see that this is the demineralized enamel. Of course, when you have such kind of case, you could totally say that this is the decay and this is the caries, but sometimes you don't have this kind of cavitation and you have the enamel there. So in this case, color is very important. So if whitish lesion, or that we say and we call white spot, is changed in brown spot, this means that it is there for a long period and some nutrition and some color from smoking is incorporated, and we get this brown spot. And I could tell that this is this kind of brown spot that we just take a probe and see if there is any cavitation. It might be cavitated here, but here the structure is sound, and when you go on this tooth with the probe, you could see that it doesn't stuck anywhere. That means that this might be a brown spot lesion, and you also do an X-ray just to support your idea. And if you couldn't see any demineralization under this spot on X-ray, you are not doing this. So lesion is clinically visible without air drying. That means that the minerals has been dissolved compared with those carious lesions that required air drying to become visible. So if you see without any drying that you have some kind of color changes, that means that we have deeper situation than in the cases when we need air dryer to see if there is some changes. When acids reach to the dentin, the dissolution of the dentin mineral starting, and demineralized dentin varies in color from that of sound dentin, and it appears more yellowish and brown. For clinicians, sometimes dentin is more difficult to understand. Is it the sound one? Is it secondary dentin, tertiary dentin, or is it dental sclerosis? So here is a schematic picture of the situation. When we have decay and we have cavitation into the enamel, like here, you have heard this before in the lectures, that when we have decay in the enamel, and first let me explain that. As you remember, this is the enamel. This is enamel-dentinal junction, this white line here, and this is dentin, yes? So when you have decay into the enamel, we always have the bigger surface on the outer part of enamel than to the inner part. But for the dentin, or for the enamel-dentin junction, which is here, when caries comes to here, it starts to widespread and it gets more wider. So now you can see that this is enamel which is demineralized, this is sound enamel. This is dentin which is demineralized, this is sound dentin. Now, like as I said, sometimes we look from the occlusal side to the tooth and we see that there is not a big lesion on the enamel. But when you go down with your bore, you could feel that dentin is too much cavitated. And this is the real true story, because sometimes clinicians tend to not realize that enamel is always less damaged in some situations. And if you see that enamel is damaged like this, you always should know that there is the bigger problem in the dentin. So, this case case like this I showed you on the last lecture, and here you could see that you see something through the enamel, you see something dark through the enamel, and you suppose that this is the caries, and indeed it is the caries, because when you take out all the enamel, you could see how demineralized the dentin is underneath. So, as long as the caries lesion is not cavitated, occasionally single microorganism but not established biofilm will present within the lesion. This means that when we don't have cavitation, like here, we don't have cavitation. This cavity we did by ourselves, yes? In this place, we have single microorganism, not the biofilm. And if the lesion is cavitated, a large number of the microorganisms enter into the animal and may build a cariogenic biofilm there as well. So if we have cavitated lesion, you should know the progression of the cavitated lesion will be faster because you already have microorganisms there and the biofilm there that will contribute to further growth of the caries and deepening of the caries. So when the sound dentin is probed, it's very interesting because when you probe sound dentin, the texture feels very hard. You could not find the spot where you can like stick. It's non-sticky. Something went wrong. Guys, could you see my presentation or not?
Yes, but now it is closed.
Yeah, something wrong. Just let me manage it. Something went wrong. Something is not. Yes. Could you see it right now?
Yes.
Yes. Okay. Let's continue. So, as I said, when you are probing the dentin, it's it's easy to feel dentin structure, because if it's sound and if it's good, you feel that this is hard and you couldn't penetrate. But when we have demineralized dentin, it's softer, and you could sense it by the probe. It's sticky and it feels like you're grabbing some dirt. So yes, dentin is very tender to probing, and you should get in your mind that the probing is very good tool to assess the situation that you have. So now I want you to show one video here about the clinical situation that we discussed, like when you can see obviously that this is the decay, and when you go down through the enamel, you could see how big the distribution in the dentin this decay has. So let's start the video. So I will say that before this tooth were done, clinicists have the radiograph, so obviously he saw the problem under the X-ray, but by visual detection, you couldn't sense that there might be some decay underneath. So as I said, the dentin, when it's demineralized, you could feel it softer. And right now you could see it very clearly. When it's soft, it chips. It starts to chip. It's not like a sound tissue. So now look at it, very good demonstration of it. And yes, if you don't remove all the decay and all the microorganisms that are there in this soft tissue, you will have, as I already mentioned, the recurrent caries. And also, if you don't go down to the very sound structure of dentin, you also might have problems with the bonding. Like, we need to have very clear, very good dentin to make a restoration and make a stick our restoration to the dentin. we'll discuss this video, and if you have any questions regarding this video after the lecture, okay? So now let's talk about the root caries. As you already know, root caries developed when we have the recession of the gingiva or some kind of inflammation or trauma on the gingival level. And this trauma also might be the vigorous toothbrushing, guys. You know, I have lots of patients who try to do their best and they think that they're cleaning and brushing properly and correctly, but they are doing the very vigorous job for our gingiva. And gingiva, in case if it's thin by a film by a tip, it starts to recede, or in other cases it starts to be inflamed. So about the toothbrushing, we will talk in cariology, but also in the periodontology a lot, and it's a very interesting case. So speaking of the caries, if you will do some trauma to the gingiva, or if it's receded, and it is receded in cases when we have elder people mostly, so we will have this kind of decay on the root. And if the cementum is abraded, even the normal brushing will do its job, okay? Because as you know, cementum is very less mineralized and it is very easy to damage. So for root caries, pathogenesis differs slightly from the enamel surface because it is very the dentinal tubule. It follows through the dentinal tubules, and microorganisms will quite easily penetrate into these already in the very early stages of the root caries formation, and the performed sclerotic dentin as well as the access to saliva and gingival fluid will slow down the progression, but root caries also tends to get more cycle around the neck of the tooth, and it's quite unique for the root caries. Like here on this picture, you could see it goes like this. And it's not a good situation because, you know, the neck of the tooth is most vulnerable place. And sometimes we have fractures right here and here where we have the decays and when we have the lost tissue. Okay, so now we will talk about the caries adjacent to the restoration, which as I already mentioned, this is situation when we have decay near the restoration or under the restoration. And we could underline here two parts, like an outer primary lesion, which is next to the restoration, and wall lesion between the restoration and the cavity. Underneath, you could see the picture like here. This is the enamel, and this is the surface lesion. This is the one part, and this is restoration, and this is the gap between the restoration and the wall of the tooth, and we will have the second part of the lesion here. So the outer primary enamel lesion is subsurface lesion, which spreads further into the enamel following the direction of a prism, and when the lesion reaches to the EDG, dentin demineralization occurs mainly along the affected dentinal tubules. So also on this picture, you could see that here we have composite restoration, and you could easily, even under the magnification, Norna magnification, you could see that we have gap, this kind of gap here, and we have decay underneath, and here we have decay too. So likewise here. Now you could see that there is a tons of restoration, one restoration, second restoration, I guess there is a third restoration too. And here is the amalgam restoration. For you to know, the amalgam is not very actual for today, and we don't use it in our practice, but with the amalgam, we have the situation when we don't have such a huge amount of caries adjacent to the restoration, but they tend to make teeth cracky. So you could observe more of the caries adjacent to the restorations to the composite materials than to the amalgam. And also on the early stages of the demineralization in caries, we tend to see white spots. And for the beginners in our career, it's sometimes difficult to take a difference between some other non-carious disease like fluorosis or opacities of the animal. And here I want to underline a very obvious difference between these carious and non-carious diseases. So first of all, you could see that the carious is quite localized disease and it develops on the plaque stagnation areas, while fluorosis or opacities or hypomineralizations appear on the tooth surfaces, like on the frontal tooth, and it doesn't have necessarily to be on the plaque stagnation areas. Also, you could see that they differ in shape and localization. And shape, sometimes the carious more or less extends under the biofilm and spreads under the biofilms. For the fluorosis or for the opacities, you could observe that their shape is not so defined like here. And also the main difference you could find is under the air drying, because if you air dry the carious lesion, it becomes obvious, and if you re-wetted it, you couldn't see it. But if you air dried fluorosis or opacities or hypomineralizations, you couldn't see any difference between dried and non-dried surfaces. Also, in cases of hypoplasia, it's very obvious that this is not a carious disease. You could observe the hypoplasia here. It's very different shape and form and structure of the enamel, and I think it's not so difficult to differ these tissues from each other. Also, there is one condition known as MIH, also molar incisal hypomineralization, which is quite often, and sometimes it is misunderstood, and people think that this is the carious, but it is not. But also the enamel is here hypomineralized, and it is very easily damaged. And sometimes we have enamel chipped and the carious progresses easily underneath it. So if you see such kind of teeth, also I have in my practice few of them, and you should know that they are not normal in the way that you couldn't bond very easily to this kind of enamel, because it's very hypomineralized. And when you are doing etching procedure, and when you want to make the good adhesion to this structure, it's absolutely not like in the case of normal enamel. And sometimes in these cases, maybe it's better to make a crown or some kind of onlay or inlay than making the standard procedure with the composite filling, because it won't stick there. And for the erosion, for you to understand, erosion has absolutely different visual effect. I don't think that you will think that this is the carious. It's not, of course, and it's more superficial and characterized by the loss of the surface of the enamel, and you could see the wear too here. So in this case, the pore volume is more increased, and appetite between the apatite crystals, and I think that obviously carious looks differently. Yeah, here we have the table of these characteristics of the carious or other diseases which are non-carious diseases, and we could see that for carious it's prominent that it is more affected to plaque stagnation areas, and it follows the expansion of the plaque in shape. It's clearly differentiated from the adjacent normal enamel, and it's more opaque than sound enamel, if not colored secondarily, and it could affect any teeth. And cavitations and breakdowns occur in a late stage of this disease. So yes, in other cases, in other scenarios, you could see that this is not so obvious for non-carious diseases. So now I will talk about the X-ray and how important in diagnosis the X-ray and other additional diagnostic methods are. For you to know, radiograph images visualize carious lesions due to the decreased radio opacity of demineralized dentin and enamel. When we do X-ray, we usually select bite wing projections to detect caries, because in bite wing projection we see these tissues without the overlapping, so we could observe the proximal surfaces. And as you know, this is the most dangerous part for caries development. And also, as you already, as we already talked about it, know that the proximal spaces are very hard to detect when there is a caries and when there is a decay. So in this case, the X-ray is mandatory, and if we want to detect caries and proximal surfaces, we always do a bite wing projections. And like here, radiographic diagnostic methods primarily focus on detection and assessment of caries lesion in proximal surfaces that cannot be clinically visualized, as well as occlusal surfaces and existing restorations. Now, I want to discuss this with you on this picture. Now, first of all, I want to underline what is the normal enamel structure and sound enamel and sound dentin. Like on this tooth, you could see this whitish cover of the tooth, and you might think that this is enamel, and you will be right, because enamel is more mineralized. So when we have more mineralized tissue, we see it more in whitish scale. And the dentin, as you know, compared with the enamel, is less mineralized. So you could see it obviously that mineral line between dentin and enamel is quite easy to detect. So when we are talking about the enamel caries or dentinal caries, we could firstly detect where the normal enamel and normal dentin is. So in this case, now we have caries, and we could see that this place, this translucency is due to the demineralization of the dentin. Now we could observe the huge underlying decay under the enamel, which is not touched, and we could see that enamel line is in good situation, in good way, but the dentin here is quite widely demineralized. And here too, the same. You could see and observe that in proximal spaces, we have demineralization of the enamel, and already a little demineralization under the enamel too in the dentin. And here also the demineralization takes place in the adjacent place of the tooth, on the both teeth. So what is the problem with these proximal spaces and surfaces? As we already say, this is the most dangerous spaces for caries development, because these teeth tend to trap the food underneath the contact area, underneath the proximate surface here. Here, in normal situation, we should have bone crest. But as you can see, here is absolutely translucency. That means that the bone tissue is lost from here. So here is only the gingiva. And as you might know, gingiva is not giving us the contrast on the X-ray. So we see this space as an empty space. So food trap here, and as long as the patient is not making the great oral cleaning with the flosses and with the rinsers, this food trap here for hours. And as you know, it starts to diminish pH, and we have frequency of the food taking and decreasing pH raised. So we trap food here for hours. Maybe somebody eat his lunch on 3 p.m. and when he got home in the evening, he brush his teeth maybe for 11 p.m. So now you have all the food you eat on lunch or on a dinner trapped in the approximate areas. And if you have this kind of big spaces underneath your contact, I mean, you have there all your breakfast and dinner here, yes? So this means that if we promote our patients to use more intraproximal brushes or flosses and make clear this place, this will diminish the risk of the cavitation of approximate spaces. Because when this kind of patient comes to you, you never saw this kind of small decays from the occlusal side. Even if you go dry, sometimes it's not easy to detect. And we're going on the X-ray and doing X-ray, and voila, we could see here lots of decays underneath the absolutely sound enamel structure. Yes. And one more thing, sometimes patients also can detect that they have decays, and when they come with this kind of tooth which is not cavitated, and they have no idea that there might be some invisible caries, it's great way to make pictures, to do some X-ray, and to give them the view of this kind of situation. Okay, because these places are really danger, and even if you do the restoration and patient won't start to do the great cleaning and to maintain the good hygiene, it might cause the secondary caries, as we already mentioned. Yes. So here, as we said, the radiographic image provides us the additional information, and in combination with other clinical examination, we could increase the number of correctly detected caries lesions. Here now, we might say that we see brown spots, and some might say that this little spot doesn't need any treatment. But in real life situation, we will do this. We will air dry this surface, then we will go by the probe, and just by the probing, we will see if we trap somewhere here, that means that it already needs to be done. But also we will do an X-ray, and on an X-ray we could see a little demineralization here underneath the enamel. So also I could see and sense that there is a darkening under this cusp, and it gives me a glimpse that there might be a bigger decay underneath, but still I need to do an X-ray to understand that my judgment is correct. Yes, so like here in this case, yes, here we could see that from this point you couldn't see anything. Of course, in my clinical eye, I could see that here might be a decay. But for the patient, it's a little bit weird, because it observes and says that, you know, I have sound structure, I don't have any cavity, and why should I believe that I have the decay there? So you go to the X-ray, you are doing X-ray, and see what? That you have such a big decay here that even you could go down and do a root canal, because your decay is already exposing your pulp horn. So when you start to go with the bore, the one great feeling is that when you start to penetrate through the enamel, you go there and you feel the resistance of an enamel, and in one moment you feel no resistance and you go in very easily. This is because the dentin, as we said, is getting softer under demineralization. So you could easily feel this kind of decays when you go penetrate the enamel, and then you couldn't see any resistance and you fall into the cavity. And now you could see how big this cavity is indeed, because all the cavity, all the decay here is because of the dentin. We have sound structure of enamel, but sometimes we couldn't leave this kind of structure because we don't have supporting dentin. And in some cases, in some scenarios, and we will talk about in restorative part of the cariology, it is hard to maintain even sound tissue, and even by the microscope or by the other technical things, when we will totally observe that this enamel is sound, it's very hard, because if we don't have supporting dentin, sometimes it's hard to not to take it. So here is cleared view of it, and you could see that pulp chamber is already opened. As I said, it is already on the horn of the pulp here. And one more thing I want to discuss is the CBCT. You might know that it's very popular and it's very informative to take CBCT scans, but it's mostly due to its capacity to give us the three-dimensional picture of the tooth, and not only the tooth, also surrounding tissue, bone, and we are doing the CBCTs when we want to see the bone structure, when we do implants, when we are going down to the root canal and we want to see what kind of the root anatomy we have. And this is a really good tool to understand all the specificity of the tooth anatomy too. But in point of the view of the caries, it is also very important to see on the CBCT the case. But some scientists declare that on CBCT we could see it more exaggerated than it's in a real life situation, and when it's when you open it, it is not so big and obvious as on the CBCT. So we couldn't say that CBCT is a primary source of diagnostic, but if you have one, it's absolutely wonderful to incorporate all this information, because now here you could see that situation here. This is a sound dentin, this is a existing restoration, and you could see how smooth the surface is and how good and clear visually you see that this is the restoration and this is the dentin. But also here you could see that this is the restoration, and under the restoration you could see the demineralization of the dentinal tissue, and you could obviously see it like with the naked eye, yes? And the same situation we could see here. We have the restoration, and no, not a caries, but here we have the restoration, and underneath we have the demineralization spot. So sometimes it's also when we do, but you know, the X-ray is the primary choice. We always do bite wings because the bite wing is not so pricey as the CBCT and also very informative. But if we have CBCT, we should take it and we should work with it and we should see it, because like here you could see the caries, like here you could see the caries, and it's very informative. In comparison with two-dimensional bite wings, the use of the three-dimensional tomography imaging yield a higher detection rate of proximal cavitation, although it is not yet ready to widespread use. And why it is not ready to widespread use? Because of the non-cost effectiveness, because it's very pricey. So, when assessing therapies, the detailed documentation of radiologic findings is essential so that changes in lesion can be tracked over a long period. So for you to know, this is not only because I want to see what's going on the X-ray, but it's mandatory to have the documentation and history of the patient. And you should have always have before you start treatment and after you start treatment X-rays. And also for follow-ups, when we have younger patients and we want to observe how the situations progress in their oral cavity, we should take bite wings and make any follow-ups for this kind of patients. I also want to discuss these pictures here. This is a very good quality, so you could see here easily where is the enamel and where is the dentin. This is the pulp horns here you could see, and this is the obvious bite wing projection, because in bite wing you couldn't overlap the tissues on each other. And now you could see that here is the demineralization, here is too, in this place too, here. And this demineralization, when it's only in the enamel, as we already learned, you could make them remineralized. So in this case, when you see such kind of damages only in the enamel, you could promote the good oral hygiene. If these patients start to use interproximal brushes or start to use flosses, and you could see how big interproximal spaces we have here. And this is because of the loss of the bone crest here, which should sit somewhere here, yeah? So in this case, if we contribute and if we motivate patient to do good oral hygiene, to use fluoride toothpaste, and to maybe to change its diet to low carb diet, maybe we will observe in 3 to 6 months the better enamel structure and remineralization. But if this caries starts to progress and go underneath the dentine, now you know that remineralization is not so easy, because dentine is very easily be damaged by the bacteria. So this is the young patient, and in her case, I would recommend mostly to be conservative, not to do all the decays, just to take a 6 month-ish, I think maybe 3 to 6 months, and give her the best directions for oral care. And after 6 months, we will make to do another set of the bite wing X-rays, and we will compare. If we don't have any progress, then we will start to do NTKs, okay? We have also on X-ray the contribution scale, where we could say if we have only radiolucency in the outer half of the enamel, like on this picture here, this is the grade A1. If we have radiolucency in the inner half of the enamel, like here, but not until the dentine, it's E2, like enamel 2. And if we have in the outer third of the dentine, the radiolucency, like this is the D1. And you should know, if you see the D1 case scenario on your X-ray, you should understand that the progression will be more or less soon than when we have this kind of scenario, okay? Because as I already mentioned, dentine is more susceptible to demineralization. And in this case, we have D2. There is not a big obvious line between these two, but you could always mention this one, because in these cases, you could see that the decay is very near to the pulp horn. So I will always more consider this one and this one, because it's very hard to realize in the real case scenarios. Also, one thing you should know about the identification of the X-ray, you know that particularly you should understand the match band effect, because this perceptual phenomenon artificially enhances the perception of contrast next to the boundary due to lateral inhibition within the eye. So at this border between light and dark surfaces, in case enamel or dentine border, a narrow, brighter strip is perceived on the brighter side of the boundary. So correspondingly, a narrow, particularly dark strip appears on the dark side of the boundary, which can incorrectly be interpreted as a dentine caries. So you could see it easily and understand it easily on the picture, because here you could see that the strip on the right side appeared darker than the one on the left side, and actually the grayscale of each strip in the right and in the left is identical. So maybe you will observe this closely when I send you this lecture, because it needs a little bit time to understand what we're talking here about. And fluorescent camera is also very actual for today in detecting the caries. Even some microscopic companies like Carl Zeiss start to incorporate it in his practice, and they have a dental microscope which has fluorescent mode, and under the fluorescent view you can see the places which are caries and which are not caries. So it's like a new trend in dentistry, and I think that it needs some time to be acknowledged, but still I think it's very nice, and if I would have this kind of feature, I would eagerly use it. Okay, so until now, if you have any questions, if not, I will start to show you some clinical cases of mine. Any questions?
No, doctor.
Okay. Now, let me give you some examples here. Like here, some of them maybe follow me on the Instagram and already saw some of these cases. It's okay, I will explain it to you now. So, like here, so this is the caries adjacent to the restoration. This is the obvious, very good example of this, because you could see here the old restoration, and you could see how decay goes deeper near the wall of the enamel and the restoration. So in this case, this is the second scenario with a lesion, which goes between the wall and the restoration. Yeah. So here we took all the decay, all the restoration, and now you can observe what kind of color the dentin is and how sound it feels. Maybe you couldn't feel it, but visually you could see the difference between dentins. This is the last look, and in this case, patient has severe wear of teeth, and we did with her also the occlusion, and we raise her calves and make the anatomy more adjacent and fit to her mouth. So yes, this is one case. So now I want you to show this. So now you could see here, this is the sixth teeth, and this is the distal contact of the sixth. And as you could see here, patient has the orthodontic braces. And as you know, under the braces, it's very hard to maintain clean and proximal surfaces, as well as other surfaces, but still the proximal surfaces are very hard to maintain. And now you could see the destruction of the enamel and underneath the dentin too. So let's go. So we started, and now you could see it clearly here, the color of the dentin and how squishy it looks, yes? And the enamel here also demineralized, more chalky white. Here we go. And as you could see, all this dirt is coming out. This is all dentin, softened dentin. Now, as I already showed you on the last lecture too, I always doing the dyeing, because if I don't dye it, I might somewhere miss something. And actually, I already knew here that I needed to go deeper, but I still doing my dyeing just to be clear. Now here you could see sound structures, sound enamel and dentin, and you might see the dentin here might appear a little bit darker, and this is the sclerotic dentin, which we talked about it. And you know that it might not be perfect in coloring, but it's very sound, and when you go with the probe, you could see that you cannot stuck, it's not soft, and it's perfect to make bonding. So one more time, to just exaggerate it, this part, the dentin needs to be filled by the probe, because sometimes color is not so easy to understand. Is it color of the sound or non-sound dentin? So you always need probe by your side to see how good and how sound the structure is. Okay. And that's it. This is a more close look here. And you could always see in my cases that I never touch the brown spots, never, because this spot is here maybe approximately for 20 or more years. So it never developed into the decay. So we could see it after the 6 months of after cleaning. We could observe it, but I could assure you that these spots never get to be a decay. Okay. yeah, this was the wall build, and then it was done by the composite material. Yes, so this is the end in this case. So here is the not very nice work, but I wanted you to show one thing here. You could see and observe easily that we have crown. This is the crown, ceramic crown, which has, I don't know why, but this kind of weird contact place. And patient obviously telling me that he always get food trapped in here. And of course I said that this is not only because we have a little brown color here, which we know that is the decay, but also because this adjacent crown restoration is not appropriate. And I motivated him to change this to the new one, which will be a lot more better, I think, because this is not appropriate. But before that, I need to do this place. I don't know if you see here this, but I already checked this on an X-ray, and now I'm going to clear it. And yes, this is the decay which is progressing under the enamel and goes down deep to the dentin. I want to show you this. No, yes. This is enamel, all damaged enamel. And this is when we take all the enamel and dentin which was damaged, and this is a little brownish colored dentin. As I already mentioned, this is this sclerotic dentin which was produced in the teeth, and it's sound and it's perfect to make bonding, and we could use it and don't take it from this tooth. And yes, we did a restoration. We intentionally take a little more space between these teeth, and this is before polishing. You could see here adjacent little spaces, and this will be polished after this. But now you could see that I tried to close the gap as much as I could, because before this patient will take out this crown and make the new one, I need this contact to work better than it was before. Okay, now situation like this, we have this is under the rubber dam already, and you could see here the situation, and here also. Now we started to take out all the, there was a filling here and here was not a filling. So in this case we have a situation when we have two scenarios, like this is the caries adjacent to the restoration and this is the primary caries here. Okay, just to understand more clearly the terms. So here we go deeper, and you could observe how dark and how not satisfied this dentin looks. You could see it easily that it's soft, yes? Just a second. It needs a little bit time. Yes, this is already cleared, and now you could see the color is still brownish, but you could see how sparkly it is, and you will feel this kind of dentin with the probe, very sound and non-sticky. So this is the very good part for you to understand the color, and tactile sensations are very good manifestation of the tissue status. And here now you could see how sparkly it is, yes? And here we go. And that's done. You should notice that these teeth were under the severe wear, and I could not make an effort to make here more prominent features of the occlusion because these teeth were all in the big wear. And another one with such kind of situation in the contact area. As you can see, it's very easy to find the decays in the contact areas. Here was the old restoration which failed. It was broken. You could see it. And you could easily see that you have this decay underneath this caries. So here is, you could say that here is a residual caries too. Now, yes, and we took all the old restoration and we could see what kind of deep cavity we have, and it still needs to be debraided. Yes, this way. Now you could see also, this is the, not today's lecture thing, but you could see how hard it is to place the rubber dam when you have deep down decays on the proximal surfaces. Now you could see that rubber dam is interrupting me here, and I started my isolation with the matrix band and with the special covering material to leak the oral fluids here, okay? And yes, that's it. So we have nice, good restoration here, and all is covered, all is sealed. So you could see and observe these brown dots here and here, and they are not danger for us, as you understand, yes? Okay, I think for the clinical part, that's okay. And now, do you have any questions? What was clear? What was unclear? Anything?
Yes, doctor, everything was clear. But I have a question. For the practice, if you were on the campus, like this, like you are doing right now?
Oh, sorry, I don't understand, Merlin. What?
Okay, I'm asking you, if you went back to the university on the campus, how the practical will be? The same way that you are doing right now? We will see picture?
No. When we are talking about the practical part, you will have the lecture as you have now, because I should show you everything and I should declare you and give you the information like this, because without this you couldn't understand any practical things. But also we have on the campus, we have special models, we have probes, we have mirrors, and you know that it's not easy to work under the mirror with the tooth, and we will start to step by step, of course, not like starting from the decay cleaning, but by the using of the probe, of the mirror, of the tooth, and how to position yourself with the patient, how to see, how to declare all these things. We will start with these basic steps, and then we'll go to the practical things like working with the bores and how to excavate and how to make the fillings and so on, because you know this course is everything about the caries, like from the start and the beginning, how to understand the process, what we're doing right now, and to feel the process, like to probe and do all this stuff by your hands, okay?
Okay, but please, if you can give them your opinion that if we do it in January or December, instead to go right now, in order to check how it will become.
My opinion, I think that right now for you to come in Georgia is good because we will start to incorporate practice. But regarding to the situation, I couldn't tell you to come here and do this thing, okay? So as you suggested, I will talk with the dean and I will talk with the staff members. Maybe it will be wise for us, for you, for me, to make the practical part, like we're doing lectures anyway, yes, to make a practical part like this hands-ons and just to see how it works for you with the boards and other stuff later in January. But I will talk about it. I will see how they see if you come here, how they think they will do all this stuff. And after that, we will tell you maybe. Okay?
Yes, doctor, this is the best choice, and sorry for
So did you
interruption.
ask it to them already or not?
We requested that, but maybe if you also request this, they will see that the doctors and the students see this as the wise option, and they will agree with us.
I don't know.
Maybe
Well,
we would.
I will talk. I will talk with them. I will talk, and it's you know what? In this case, it's always hard because, guys, the lectures and the hands-ons, or I mean, practical courses, they are done in like together, and this is most effective part when I tell you all this stuff, lecturing all this stuff, and then we will start to do it. It's always the most efficient way to conduct the information and to study it. And I understand that university wants for you the best, but maybe it will work in that way too. Maybe we will do our lecturing part for this semester or for until December, and then in January maybe we will do a practical part. Okay, any other question regarding the cariology, regarding the cases you already saw? And also I want to ask, is it good for you when I'm incorporating these practical pictures from my daily work? Is it work for you?
Yes, very.
Okay. Inform us about the result. I don't know. I need to talk with them. Yeah, what about, I don't upload the PPT on the drive, guys, because this is my PPTs and I just don't want them to be used in any other cases. And I will send the both PPTs, the second one and this third one, to your emails, okay? I think it will work for you anyway. Yeah.
Okay, thank you, Doctor.
Yeah. Okay. Also, I had the question here from one of the students. I'm sorry I couldn't write the answer. And the question was about the exam, OSCE, and about the marks, yes, and about the OSCE. You know that the OSCE is a clinical examination. You already have it, and you know what? To do OSCE, we need to have a practical examination. So if we will have it in January, we will have all the details about the OSCE to discuss in January. Right now, what about the marks? Marks, I couldn't now grade you because we don't have the tutorial part, as you know, until we will be in online regimen. And after we go on campus, if we go on campus, we should have tutorials too. But until now, they tell me that we don't have any tutorial 2 hours. So I'm just lecturing and I'm not putting any marks. But I'm doing, like, I know who is absent and who is here with us. And I think this is also, this will be maybe also the thing when we will talk about and discuss about marks. So until now, I think this is everything I wanted to say. So if you have no questions, I think you don't have any questions, yes? Okay, guys, I want to say thank you and to hope to see you. Maybe not on the next lecture, maybe on maybe January. But anyway, take care and goodbye. Okay.